any super deep theory about head trauma. It'll be kept very practical. What you need to learn, what you need to know as a first opinion or an ECC vet. So we'll start off by talking a bit about the pathophysiology, and then we'll talk about emergency treatment, briefly cover the neuro exam, which is quite important, and then probably the most relevant part of the talk, I'll talk about decision making, about whether you keep it in-house or whether you decide to refer the dog, and then everything else, neuroimaging and decompressive surgery won't be directly relevant, but we can briefly cover it so you know which dog, well, you will be able to identify which dog may benefit from neuroimaging and or decompressive surgery, and then we'll talk about treatment in-house, and finally prognosis. So head trauma is usually caused by really severe trauma, so falling off the sofa or down the stairs usually isn't enough to cause any significant head trauma. The dog really has to get hit quite hard, and in this country by far it's going to be an RTA that's caused head trauma. In my experience, I've hardly ever seen any other causes of head trauma. It's almost always an RTA. Horses, dogs that run around yards potentially could get kicked in the head, but dogs are quite clever, I think. I've never actually seen a dog that's been significantly injured by a horse to that extent. Falls from height if possible, falling off bridges, off cliffs if dogs are walking out in the mountains, and also, unfortunately, very rarely, but we do see intentional abuse sometimes. Unlike RTAs where they break legs, usually if someone's trying to abuse a dog, they're going to hit the head or the trunk, and that's going to cause spinal or head trauma. Head trauma could either be blunt or penetrating depending on what's hitting the dog. So dog bites can also cause head trauma, big dog versus little dog kind of incidents. And firearms, not less relevant in this country, but sometimes seen. So pathophysiology, you may have heard of the primary injury and then the secondary and tertiary injury. So neurologists will always talk about the primary injury, which is what happens when the head first hits the object, and then you get the direct injury to the brain. But what happens in the seconds, minutes to hours after the injury is the secondary and tertiary injury, and that's all mediated by vessels, the immune cells and whatever. If you want to talk about it at a cellular level, head trauma leads to direct parenchymal damage, and then that causes disruption to a whole bunch of things and a cascade and whatever, it all happens. But really this isn't important at all because no one really cares about what goes on in the middle. All you need to remember is that head trauma can lead to an increased intracranial pressure, and that's all that's relevant for clinical practice. Everything that happens in the middle, it's nice to know if you're interested, but you can't really do anything about it. In the end, all treatment is going to be directed at the intracranial pressure, and all monitoring is going to be looking at that anyway. So the first step of head trauma management is to recognize that the patient's got head trauma. So usually an appropriate history will come with the dog. If there is an appropriate history, there's no history of trauma, I'd be a bit reluctant to say that this dog that's been stretchered in has got head trauma. I consider other things first because it's far more likely that it's got some metabolic disease or whatever. But if the owner says dog's been kicked by a horse, or I've seen it been hit by a car, and it's got the appropriate clinical signs to suggest that it's got intracranial abnormalities such as the following, then yep, head trauma should be suspected, and then you can start to think about how you're going to manage this dog emergently and later into the course of its stay. So because we've had this talk today, maybe head trauma will be on your mind for the next few days, but like I said, it's just not very common to see it in practice. It's much more common if a dog's being brought in unresponsive, that something else is going on with it. Very rarely it's an actual intracranial problem, so just be careful that other non-neural mimics can give you clinical signs like this and make you think that it's actually got a neural problem when it really doesn't. If it doesn't have any trauma in history, again, just be very careful about saying it's got head trauma if there's nothing to suspect it. So you all know this. If you're thinking head trauma, you need to do the ABCs, the emergency treatment, secure the airway, make sure it's breathing, and make sure that the heart's pumping fine. For head trauma, I've added another couple more. which is to check its glucose and also to control any seizures. The books will say that you do this later on, but this is kind of something that you just do when the dog comes in, isn't it? And it's always good to get on top of it before you wait half an hour to sort this out. I'll explain why this glucose and seizures will be relevant later on when we talk about treatment in more detail. Of course, when you're doing your emergency treatment, you'll survey the dog for other injuries. When the dog's comfortable with pain relief, you check whether it's got spinal trauma, orthopedic trauma, do your focus, just make sure that all the other systems are okay. So let's say you've done all that and now you stabilize the dog. Then we do our neuro exam. So classically, if you pick up any textbook, you'll find that you find the neuro exam here. But if the dog's on its side, you're not really going to be able to do much of this at all. So the modified Glasgow Coma scale is a modified neuro exam for head trauma, and if you don't do the full neuro exam, that's fine. As long as you do the MGCS, you'll be able to monitor and trend what's going on with the dog, and I'll go through this in a bit of detail now. So it's quite simple. Excuse me. You just have 3 areas of assessment: motor activity, brainstem reflexes, and level of consciousness. So just 3 assessment points, and each one of those is scored 1 to 6 to a total of 18. 6 is the best score, meaning the dog's fine, and 1 is the lowest score, meaning the dog is almost dead. And I'll show you how to get the MGCS score and how you can use it in practice. So the first point of assessment is motor activity. So it's scored 6 to 1, be best to worst in that order. So it's really quite it's a bit like the neuro exam when you assess mentation, gait and posture. You're just seeing how the dog is able to walk or not. So as you go down the scale, you see that the gait just deteriorates. It's walking fine, normal spinal reflexes, and then if the head trauma gets worse, it's going to start to become paretic on one side or both sides, and then it might start to develop rigidity in all 4 limbs. And as you get worse, it just starts to lose its strength, goes from being paretic to non-ambulatory, and starts to get worse rigidity, starts to get worse, and it starts to extend its neck, a bit like you all know the death stretch with the dogs do in the kennel when they're about to die. So it just starts to look like that. So after you've so these 2 generally mean the dog's okay, and if you're getting 4 to 1, it means the dog's not okay. Same for the brainstem reflexes. So you start off normal. You've got normal PRRs and normal oculocephalic reflexes, but as you start to get worse head trauma and increase intracranial pressure, it just starts to get a bit slower. And then the first thing you develop is bilateral meiosis and very reduced oculocephalic reflexes. And as it starts to get worse, you get mydriasis. So some people wonder why it goes small and then it goes big, and that's because the sympathetic pathway is much more fragile. So once you have a little bit of NICP increase, that's when the pathway first goes, and then you get an overload of parasympathetic, so it goes small. And then once the ICP gets even worse, and then it progresses and all the fibers go, and then you get unregulated sympathetic firing, and then you get bilateral mydriasis. So same as the first point of assessment, motor activity. If your dog is scoring 6 to 5, then it's generally okay. But once you start scoring 1 to 4, then you should be worried. And finally, the level of consciousness, a bit like the hands-off neuro exam, where you just grade the dog on how alert it is. And same as the others. So once you've done your 3 points of assessment, you'll be able to give the dog a score out of 18, and this will be useful because it allows you to semi-objectively monitor the dog across its stay in hospital, and it might allow prognostication, which we'll cover later on. So it's quite useful for monitoring progression, and it's also useful for handing over care, because if you get a score of 16 coming in, for example, you might think the dog's okay, and then if you see it going down to 14, 10, you know that it is getting worse, and you will be able to identify this quickly. if you had to look at someone's notes, because when we write free text, no one does it the same. It's less easy to identify that and spot any trends. If you printed out the form and you got every colleague to do the MGCS every however many hours, you'll be able to see the trend very easily. It also allows an easy handover of care. Instead of taking 10 minutes to hand over a case, you can just say very succinctly in one sentence, this dog has been an MGCS of 4 at its worst, and it's now an 8 and a 12, and it's getting better, and nice and easy handover. And there are a couple of papers that have looked at the MGCS in dogs. These two papers here, if anyone would like them, you can always, and that doesn't have access. I think that one's open access, but if you want this one, you can just email us and I'll send it to you. They look at the MGCS and they show that a lower MGCS is associated with a worse outcome, and dogs are less likely to get discharged the lower the MGCS gets. Right, so now you've recognized head trauma, you stabilized the dog, you've done your neuro exam and the modified Glasgow Coma score. Before you do any other head trauma treatment, don't forget the spine. Anything that hits the dog hard enough to give it significant head trauma could injure the cervical spine as well. If it's something like an RTA, it could also have fractures elsewhere. So don't forget cervical spinal trauma, especially since if the dog is recumbent and non-responsive, it is impossible for you to check the spine with your neuro exam, so you're going to have to perform some imaging. So the next step, if budget allows, you could consider imaging of the spine with either CT or radiographs. And this is a very old discussion about how CT is better, how radiographs are not good enough. But radiographs can pick up very displaced fractures. It won't pick up non-displaced or very subtle fractures. But if it's the only thing you've got, it's the only thing you've got. And if referral is not an option, you may want to perform survey radiographs of the cervical and thoracolumbar spine. If money is a concern, spinal trauma isn't the dog's main concern. It's got a brain that's about to explode. Save the money for treatment of the head trauma and worry about the spine later on. And then neuroimaging. So a common referral we get is that the dog's got head trauma and then they're referring it for MRI. Sometimes some of them have CT and they don't think CT is useful, and they're not sure about when's the best time to refer. So the thing about head trauma is that not every dog requires neuroimaging, and even fewer dogs ever require any surgery. The vast majority of dogs with head trauma will be able to be managed with medical management, and you give them time, manage them appropriately, and they will get better and leave the hospital. If they're very bad, if the MGCS is very bad, then of course, it doesn't matter where they are, whether you do it or we do it, they might not survive. So there are really only two reasons to refer. If you think that very intensive management of the intracranial pressure is required, or you suspect a surgical lesion, which I'll get to in a second, what we shouldn't be doing is to put in the referral form, referring this dog for CT or MRI, because not every dog requires imaging, and the imaging rarely benefits the dog itself, unless we're thinking one of those two. Yep. So less than 1% of dogs with head trauma will ever need surgery, and medical management is usually sufficient in most cases. So we'll briefly talk about surgery for head trauma. So there are two reasons why we would want to go into the skull. And the reasons are because there's something in there that's pressing on the brain. It's that simple. So the only two conditions after head trauma that would lead to surgery is if the dog's got a space-occupying skull fracture or space-occupying intracranial hemorrhage. The thing with skull fractures is that they sound not very pleasant, but really very few skull fractures ever need surgery. You really only will consider surgery in the space-occupying or the open fractures. What I mean are these kind of fractures here, where there is a visible defect through the skin, the subcutaneous, the muscle, and then the skull. with possible bits of brain in the hole, bits of skull in the hole. If it's anything like the other two here, this fracture here you'll never be able to diagnose on an exam because you won't feel it. It's not displaced and it's not unstable. This one, if you're very careful, you might be able to feel it. But if it's closed and it's not causing any significant compression, these can also be managed conservatively. So it's really quite simple to answer. It's quite simple to decide whether the dog needs surgery. Is the systemic compromise so bad from the ICP that you think the dog has got a bleed that's not going to resolve or is just going to get worse by the hour? Yes, then you probably should refer it to a place that might be able to scan it and perform decompressive surgery to get the blood clot out. Or if the dog has a gaping hole in its head, then that dog probably needs surgery as well. So to summarize thus far, we've talked about recognizing head trauma, the initial ABCs and the additional glucose and the seizures, how you examine and monitor dogs with head trauma, and so now we'll move on to medical management of head trauma. So let's say you decide to manage it in-house. Let's say none of those conditions are fulfilled. You don't think the dog needs surgery. You don't think it's a severe case of raised intracranial pressure. You don't think that this dog has a progressive bleed that's going to get worse or need surgery. You decide to manage it in-house yourself. So we'll talk about the goals, the two goals of managing medical management of head trauma. So earlier I did show you those three boxes there. Head trauma basically leads to increased intracranial pressure through a bunch of complex pathways which we're not interested in. But after that, increased intracranial pressure will lead to decreased cerebral perfusion pressure. So the two goals of management are to bring this down and to keep this up, so that the brain gets the oxygen it needs, and then it's not going to just slowly die off. So for the first one, so we want to reduce the intracranial pressure, and there are really two ways to do this. You can elevate the forequarters of the dog 30 degrees, and it just helps promoting venous drainage through the jugulars. Also, forgot to put there, but avoiding jugular sticks, occluding the jugular, will just increase the intracranial pressure. And to actively reduce the ICP, you can give it mannitol at these doses. But I'm sure you're all aware, mannitol dehydrates the interstitial tissue, so you need to follow this up with an isotonic crystalloid. And then maintaining cerebral perfusion pressure. Even though I put it on two separate slides, the ICP and the cerebral perfusion pressure, they are really two sides of the same coin. If the ICP goes up, the cerebral perfusion pressure goes down, and vice versa. So if you decrease the ICP, you are already increasing the CPP. However, these strategies here directly maintain the CPP through the body's own homeostatic mechanisms. So the idea is just to keep the dog normal tensive, normal volemic, normal oxemic, and normal capnic, because any changes in this, the body is going to react, as you know, by vasoconstricting, vasodilating, and that's going to change the cerebral perfusion pressure. So just by maintaining everything as normal as you can, while the dog is hooked up to a multi-parameter, is all you're aiming to do. Some texts would describe the use of hypertonic saline to increase the intravascular volume and also decrease a little bit of the intracranial pressure. It's a bit like mannitol, and if you want to use, and then apart from the ICP and the CPP, we've got to think about seizures. If the dog is starting to develop seizures, or you think it is at risk of developing seizures, then give an anti-seizure medication. It doesn't have to be LEV. It's just my preference because it has the fewest adverse effects, relatively cheap and quite easy to use, and then you can follow it up with the tablet at home if you want. If you want to use phenobarb, benzodiazepines or propofol, it's up to you. Just control the seizures somehow. And then the reason why we want to maintain normal glycemia and normal thermia is there's something in the brain about the cellular I can't remember the exact details, but if the glucose is too high or too low, then that's gonna be directly toxic to the brain tissue. So checking the glucose the moment the dog comes in and regularly as the dog stays in is important in head trauma as well. So why I put corticosteroids there is because if you remember this diagram from earlier, there's a little bit here, inflammation. So in the past, many people will give steroids for dogs with head trauma or spinal trauma in a bit to reduce the inflammation in the central nervous system, but there's no evidence that that helps, and it is actually harmful. So corticosteroids are not recommended in head trauma. And so you're doing all this treatment, the client will at some point ask, what is the dog's outlook like, and do you think the dog's going to go whole? So this was from one of the papers earlier. I think it's the paper that's freely available, and they've done statistics to show that if your Glasgow coma score is something like 15 and above, very likely to survive. If the coma score is 4 and below, you're very unlikely to survive, and anything in between is a bit of a toss-up. So this might be useful to advise your clients. If it's in the middle, it might survive, it might not. If it's really bad, probably talk about euthanasia. The limitations of this paper is just that I think it had 32 or 38 dogs, so not that many dogs at all, as with every other study that we've got, so take it with a pinch of salt. And so I've come up with this algorithm here, which is to try to be a quick reference tool for any head trauma, and we basically covered all of this. So first step is you just need to recognize. You need to recognize, and feel free to take a picture if you want to. I can send the slides out if you ask Alan. Just send the slides to you, and you can keep them. So first step is to recognize head trauma. Perform your ABC, glucose and seizure control. Do your neuro exam and modify Glasgow coma score, and then consider imaging. Don't forget the spine. Remember, we're not doing CT or radiographs for the head, we're doing it for the spine to make sure we haven't got something else elsewhere. If they have cause concerns, just skip imaging. There's no point imaging anything to do screening for a problem that may or may not be there. If you've done your imaging in-house, if you're lucky enough to have CT, and you find a skull or spinal fracture, then you probably need to seek advice to see what you need to do with this this fracture here, which may or may not include referral. If you don't find any fractures, then that's good. Of course, if you're using radiographs, just be aware that you might be missing stuff, but if you don't see any fractures, then you need to make the decision, do you need to refer? And it's really just those 3 questions. Is this dog having really severe raised intracranial pressure and clinical signs that I'm not comfortable managing, or does it have a big hole in its head and it's going to need surgery? If it's yes to any of them, refer it, and if you answer no to all of those, manage it in-house, and you've got the Glasgow coma score to help you. And so that's a summary in words.